Okay, so moving on to the journal club of this week. And just a reminder, you can do a journal club in a lot of ways, but in general, your analysis of a paper can be done probabilistically, just like your approach to a patient. And there's different formulas, and they look somewhat similar to this. That you have some kind of pre-test probability assessment where you need to know what is the evidence in this area that I'm about to research or do my like the paper that we're looking at. What does the general knowledge right now say, both from a biomechanical standpoint, like how plausible is this hypothesis that the paper that we're looking at is testing, and also how likely is it to be true given the evidence or the papers that have been done so far. So where does it fit in the landscape of evidence right now in this area? And you might need to use evidence from areas that are in the vicinity of the thing that you're looking at right now. For instance, if you're looking at tranexamic acid for GI bleeds, you might want to take a look at tranexamic acid for trauma and for other kinds of bleeds like nosebleeds and all, as they did in the journal jam from EM cases. You can check that out if you want to. So, and that's a good example of how not exactly the same studies or evidence area has to be utilized. Like you have to utilize more than just the specific area that you're in right now. Another example would be if you're looking at thrombolysis and stroke, for instance. You might look at not only streptokinase or alteplase. You might also look at the newer ones, tenecteplase. You might look at thrombolysis literature from other areas, like in PCI, not in PCI, but ACS or in PE, to look at for instance, what are the risks. So you can like, when we're giving these drugs, what are the risks across span of different conditions, and if your study is an outlier as compared to those other areas of study, then you should be cautious with your interpretation, right? Yeah. Bioplausibility is important, and it's something that can oftentimes lead you astray as well, because lots of things can be bioplausible. If you look at, for instance, the YouTuber and doctor Midlife Crisis, or Rohan, I can't remember his last name, but he made this video on what he called the mechanistic bias. I've talked about this before as well. That you can convince yourself that a hypothesis is bioplausible. For instance, if you take the stroke example again, you might think that if you give thrombolysis to someone who's just had a stroke, because thrombolysis is something that lyses or dissolves thrombi, then it should be obvious that giving that should make everyone 100% healthy, right? That would be a very simplified biomechanical or bioplausibility argument. Of course, there's nuances, and you can make your models of bioplausibility more and more nuanced. But at some point, there needs to be some kind of bioplausibility. This goes back to the Hill's criteria, right? How things work. We want to kind of know the pathology and your pathogenesis and your physiology, as well as the evidence in the area. And oftentimes these two areas, the evidence and the biomechanical arguments or explanations of how things work, are mismatching, and that's when you have to like think, what is wrong? Is the evidence wrong? Have you done the wrong studies? Have you done it in the wrong way? or is our model or paradigm wrong about how we think about this? So okay, then from this you'll have some kind of pretest probability. How likely is it that this study is true, that we're going to analyze, right? And then you dive into the study itself, and I usually start with the big questions that I'll go into, because as Justin Morgenstern explains, and many other much more experienced journal clubbers than I often explains, is that interpreting a study is not about looking at the study from a statistical viewpoint. It's much more important to kind of fathom the bigger, broader lines of the methodology of the study. Why did they do this study? What is the question that they're trying to answer? And is the tool that they chose in the methodology section, the tool that is the study for that particular question, is that a valid tool? Or should they have chosen something else? Is the power calculation good enough? Are there enough patients in this? Like, how would you go about doing this study? Like, these are the bigger questions that are often missed when you're doing a journal club, because you can be deep into the specifics of p-values and so on and so forth, and then like disregard the bigger picture, that is, this study should never have been done, or it doesn't matter what the p-values is, or because this study is just made in a way that it cannot answer the question that it set out to answer. So Justin Morgenstern from First 10EM is one amongst many who are really good at like cutting through these like studies and like going through the hype of these, and then just analyzing it in a good way. So that's the big questions before you jump into your own analysis. And then the analysis is usually, you have the PCOS, the patient population, the intervention, the control, the outcome, and the study type. This is, of course, if it's a trial. If it's not a trial, meaning that it might be a retrospective study, or it might be a prospective study, but it's not a controlled trial. It's not a randomized controlled trial, but it's some kind of other like observational study. Then you might not be able to use entirely the PCOS model, but something like this, you need to like get the data mine the study, and then see data mine the PCOS, like, and then the results section. And then once you've done the results section, you kind of know, like, do we believe the results? What is the and to answer that question, you do what you call a quality checklist, where lots of these questions are embedded that are important to that specific design, whether we believe both the internal, like especially the internal validity of the study, like do we believe what has been done? And then we can ask the broader questions later on here, back to reality, like the external generalizability, like or the external validity of the study, like can I use it in my practice? And as the EBM 2.0 paradigm tells us, like when we're doing this in a probabilistic way, we can kind of use the study as a likelihood ratio. The p-values are like the p-values of the results, if we believe them, are kind of like likelihood ratios. So if there's a really, really tiny p-value, then there's a higher likelihood that these results are true. And if you had a moderate pretest probability before, then maybe you now are above some kind of threshold to actually implement this, like the knowledge from this. But it's all about where you start in the pretest probability. That's partly subjective, like where we start in this. And that's why, as Simon Carley, one of the professors in emergency medicine, has pointed out in a blog, that even though we might agree on the study and how we interpret the study, then we might come to different conclusions about what to do with it. Like we might both agree that the likelihood ratio is maybe 5 or 10, but if we come at it from different pretest probability standpoints, then one might come from a low pretest probability standpoint, and if you come from a low pretest probability standpoint, with a likelihood ratio of 10 as your test, then even a 10 might not fully convince you or get you up to a post-test probability that is high enough. Whereas if you're moderate or high pre-test probability, like you believe in this area, then you will only believe even more after the study, right? So it depends where you're coming from. Okay. I always show this because there's the sketch, I think it's called Sketchy EBM or Sketched EBM YouTube channel, have like great visuals about where in a study do you find the important bits. And the method section of a study is the most important when it comes to interpretation, right? The introduction is usually just information about what has come before this study, why is this study even done according to the authors, and the end of the introduction is usually the purpose of this specific study. All right. And then the discussion section is actually the discussion section is just how the authors interpret the method and results section. So actually you don't need those. You don't need the conclusion and discussion, and you don't need the introduction if you know the area you're going into. You need the method section, and that's why there's a hard argument I believe is very good, that all studies that are being published should not be published according to the results. They should be published before even getting before they got the results. The publishers should agree to publish the study no matter what the results are, because it's not whether or not they're negative or positive that is important. The methodology is the important bit, right? If it's a really sound methodology study, then I want to see it whether it's negative or positive. And that's why we have this like publication bias where only the positive studies get published. And that's one of many suggested solutions to this problem. All right. I think I've stated the more important bits about this, and we'll move on to the Journal Club. Okay, so the background for this particular area, this Journal Club today is going to be about the ADvISED trial, and it's about D-dimer and aortic dissection. So we'll just have a small prelude before, like, what is this area? Why is this important to go into this? So the thing is, if we have here a Bayesian chart, then we know the tests can be like weights. They can be likelihood ratio positive +2, +5, +10, which in a simplified way might increase the risk, the likelihood ratio. Sorry, increase the post-test probability 15%, 30%, or 45%, and vice versa with and the same if it's a negative likelihood ratio. +2 is the same as -0.5, +5 is the same as -0.2, and +10 is the same as -0.1. The D-dimer in a acute aortic dissection has a likelihood ratio, a negative likelihood ratio of 0.05, which is really good, and a positive likelihood ratio of +2, right? So if it's positive, it almost doesn't change the direction of the needle, but if it's negative, it does reduce the risk highly. And then the pretest probability in the aortic dissection is maybe 2 to 4 in 100,000. This is really hard to assess because lots of the studies being done is something where or at least done in the ED, it's really hard to assess which patient should be worked up in the ED, as we'll go into. But on the population level, we know from the IRAD, the aortic dissection, I can't remember what IRAD stands for, IRAD, but it's the big organization collecting data about aortic dissection. And they would say around this is the chart. This is the number of people getting this. So it's a really rare disease. So depending on whether you have a low, so depending on when the patient arrives in the ED, like if you screen everyone who arrives in the ED, you will not find that needle in the haystack. But if you have a predisposability that is 0.5, then you like the patient will still be a really low risk after that. But if you do increase the predisposability somewhat, you will have you will decrease with negative D-dimer. You will come down to quite a good predisposition probability. But as the risk increases, that's not the fact. And the higher the problem, the higher predisposibility, the more likely you are to need more tests. The thing is with aortic dissection is that it's really hard to assess the predisposibility, which patients should be worked up. So that's kind of why we need some kind of score, maybe, to kind of standardize how to work these patients up. That's at least something that's missing, like how to assess the predisposability of these patients. Okay, so that was really quickly about the background and why we might need more than this D-dimer for the aortic dissection assessment. You can go much more into the background if you want to, but I'll leave it at that. Now we move on to the other part of the background, which is our assessment of our predisposability. So as we talked about, it can be like the epidemiology of this can be built into like the physiological argument, like why would a D-dimer work in accordance with some kind of predisposability assessment? Well, it would work because for every dissection there might be often there's a clot, and the clots a clot formation will make the D-dimer go up, right? So it's something that will be somewhat sensitive, but probably not that as specific, as we also see with the likelihood ratios up to, or positive likelihood ratio up to, meaning that it's like if it's positive, then well, it doesn't change that much, but if it's negative, then it changes a lot, because most aortic dissections have clots formations apparently. Or at least most aortic dissection have D-dimer going up, but not all of them. And that's kind of the how low do we want to go? How low a post-test probability do we accept as an acceptable miss rate for these patients? That's one of the core questions in this area, and why this is such an important and interesting journal club. Okay. So physiologically it makes sense, but we also know that we might miss some. It doesn't make perfect sense. There are some aortic dissections that are D-dimer negative for some reason, and which ones, or might not be D-dimer negative, but might be, well, yeah, might be D-dimer negative, and even though they have a dissection. Then the imperism, like what you call, like this is when then your experience-based epistemology, like how do we know? We know from informal, like what do I know from what I have experienced myself, and I haven't used the D-dimer myself that much before. Have I seen cases where there's a D-dimer where there's a aortic dissection with a negative D-dimer? Yes, I've read some of the studies. So, but I don't have my own experience with it. And the formal says like there's no good prospective studies studying the risk score, ADvISED score, and the D-dimer before this study. So this is the first study, but we saw from some of the other just data that I showed you on the previous slide from ASHA that the D-dimer might be a promising tool in this area, but it all depends on how we assess the pretest probability and what the acceptable miss rate is. Then traditionalism tells us that, we don't really dare to use blood tests to rule these patients out. When you think about it, you should scan. The problem is there's a diagnostic creep going on, right? And which patients should we actually, we can't scan all of them. And there's definitely a lot of patients that we don't scan, but do kind of present with a acute chest pain, but it might not be radiating to the back, or they might not have the age, or they might not have the risk factors. So how do we guesstimate, or how do we use our gestalt, or how do we do this in a way so that it's more systematic? Or should we just do it in a gestalt way? That might be good enough. I don't know. That's what we're trying to think about here. So the thing I just skipped a little bit was, where does that put us in our pretest assessment, right? Where does that put us before going into the study? Are we at a low pretest probability? Do we think this concept will work? And I think from the evidence, it might work. It all depends on how far down we want to go into the post-test probability before we call it ruled out, and how many extra scans we're willing to do. So it's a lot of this is about cost-benefit analysis, particularly because it's such a rare disease. And there's a high risk that we will have a hard time finding this needle in the haystack. Or is it worth finding the few needles in the quite big haystack of mainly chest pain, to just find these few needles? Is that worth it? And are we doing too many CT scans to find those? That's kind of the problem. So this ADvISED study proposes that we should use, or we might, it studies the assessment of the pretest probability via a score called the Aortic Dissection score, or the ADDRS score. And the ADDRS score is made up of 3 columns. And there's predisposing conditions, pain features, and physical exam. And you can get 1 point from each column, meaning that if you have 2 of these, it only gives you 1 point, right? So you can have as many of these features as you want, it only gives you 1 point, right? So you can maximally get 3 points and minimally get 0 points. One thing I always thought was a little bit odd with this score is that you can have according to this score, you can have a score of 0 but still have a risk of aortic dissection. And I always think, well, if you don't have any of these pain features, how do we think about this being an aortic dissection? What kind of presentation is it? And then we'll go into that, but it's mainly like back pain instead of chest pain. That is not necessarily abrupt in onset. It might be stomach pain, might be pain somewhere else. It might be, or it might not be pain at all. It might be painless ones. It might be it might be syncope, and so on. There might be some areas where there are pain-free aortic dissections, and as we talked about earlier, that might be around 5% only. So most patients we will see will have a score of 1. And then the thing is whether they have more than 1. And then there are some definitions to be just talked about here. The pulse deficit, or a deficit in the SBP has to be more than 20 millimeters of mercury to be valid. The pain severity has to be NRS of 10. Aortic valve disease is, for instance, a TVAR. TAA is a known aortic enlargement. They don't specify how many centimeters it has to be. Recent aortic manipulations could be a coronary or aortic angiography, a CABG, or aortic operation. Neurodeficits should be in cranial nerves, motor sensory nerves, or coma, and hypotension should be defined as an SBP of below 90. This is from the supplemental material of the ADvISED trial. Okay, so the ADDRS trial, here we have either you have 0 or 1, and you become a low to moderate risk, and the D-dimer will then decide whether or not you need a CT scan or not. If you have a high risk score, meaning 2 or more, then you will go on to the CT scan no matter what. That is the usual way of doing this before this trial, and yeah. And this is just a overview of the different studies on D-dimer and aortic dissection. So there's been a lot of these studies, right? And where does so the sensitivity is somewhat around 90 something percent. I think the sensitivity is 0.99, but a spread of a little bit more. This is from Ken Mellon, but I'm just saying, just to say that there's been a lot of studies, and the sensitivity is 97%, and the specificity is 56%. That's without the ADDRS score, so it's quite big, quite high sensitivity. So what we're hoping for, I guess, is to make this even more specific. Okay, so the 3 questions in this, now we jump to the analysis bit. And what is the question the study tries to answer? Well, the study tries to answer whether or not the ADDRS score and a D-dimer applied to that can safely rule out aortic dissection in patients presenting with a risk or suspected aortic dissection, as opposed to just doing CT scans on them. So we're trying to spare CT scans on these patients that we might think have aortic dissection. That's kind of that's the main thing here. What do I do in my clinical work? Well, for this particular question, and does what they do in this study somewhat look like what I do? Well, no, this is a new kind of way of doing things, at least when the study was done in 2018. This was a new way of doing it. I hadn't used the ADDRS score before this study, and usually if we think about aortic dissection, we will just do the CT scan, right? So it's really relevant for us to, if we can reduce CT scans in certain populations, then yes. Then we can always come back to the question whether, in emergency medicine, if you have a severe tearing chest pain, there are other differential diagnoses that you might want to consider, despite or besides only the aortic dissections. You might find other conditions doing your CT scan that you might be interested in nonetheless. So maybe you don't want to spare that CT scan even if the D-dimer and ADDRS score is normal. So that's something to think about. Moving on. And then how would the ideal study design look for this? Well, so I would probably, when it comes to doing some kind of protocolized study like this, where you want to test some kind of, you want to externally validate some kind of score and D-dimer, then I think the best study would be a cluster randomized controlled trial, where you have different hospitals doing, you have some hospitals doing this thing, like the ADDRS score and the D-dimer, and then you have other hospitals who are not doing this, but very similar hospitals to the ones that are in the intervention group, right? And see how many are missed. And you need quite a big study over years and years, because this is a really rare condition. So you might not get the numbers that you need in only a few years. You need either a lot of hospitals and or a lot of years, or both, right? So I think that's how I would go about. But so as we go into the PICOs and the study analysis, think about like my answers and what your own answers would be to these questions, because this kind of gauges or acts as a template for what the ideal study design would be, as opposed to what was actually there. And that's what from this mismatch between what we thought is the ideal and what the study actually did, is a lot of like, this is where our critique of the study comes in. A lot of the questions comes like naturally from that mismatch. So the ADvISED trial from Nazarian et al. 2018, called the ADvISED trial, or Diagnostic Accuracy of the Aortic Dissection Detection Risk Score, ADDRS score, plus D-dimer for acute aortic dissection, or acute aortic syndrome as they call it. The ADvISED prospective multicenter study. So start with a case. You have a 53-year-old man, ex-smoker, and has hypertension. He comes into ED with an intense central chest pain radiating to the back. He describes it as tearing, it came on with a maximal intensity from like seconds. The onset was seconds, and it was intense pain from the get-go. And it has 4 hours. It's 4 hours since it began. The ECG looks okay, and his ABC stable right now. How would you proceed? Would you do the CT scan, or would you do something else? So the PICOs is like this. So they included everyone above 18 years of age with a suspicion of aortic dissection, and this is important. How did they do this? How did they sieve these patients, or how did they collect these patients, cherry pick these patients with the suspected aortic dissection? We'll come back to that probably, but that is important because it's mainly physician gestalt that drives which patients came into this study. But they had some things that they looked for. There was chest pain, belly pain, back pain, syncope, or signs of perfusion deficits, which was not specified as I could find. And then it was attending physician was evaluating whether acute aortic dissection was a fair differential in this presentation. So these presentations, but also like, is this fair? It seems like they didn't include all chest pains and all belly pains and all back pains. They didn't do that. That would be wasteful, I think. So they had someone gestalt or guesstimate which ones should be included. Okay. The exclusions were trauma, or patients who didn't want to be in the study, or so who couldn't be followed up. There was no intervention because this is a prospective study, but it's not a RCT, so no control either. And the outcome they tried to measure was the diagnostic accuracy of ADDRS plus D-dimer, especially with the ADDRS being 0 or 1. The gold standard was a CTA MRA, as meaning MRI with a angiography component, or a TEE. Those were what they considered gold standard. And then it was what I would call a bronze standard. If the patient did not reappear within 14 days for question follow-up, if they didn't get these scans, they would get a 14 days follow-up, and we could ask about that later. We could talk about that later, whether that's long enough for a potential missed aortic dissection to fully develop and kill the patient, or we'll see. What kind of study was this then? The S. And this was a multi-center, 6 centers, 4 countries, prospective observational study from September in 2014 to December in 2016. They say that the patients were consecutive, meaning that it was both day and night. that they ruled in these patients. And there was a follow-up 14 days after. So the results. So this is the table 1, where it's important to just look through the patients lists and see whether these patients looks like patients that you see in your everyday. It's a little bit more male than female. 60%, 60 versus 40% male versus female. Age is around 60 years of age, ranging from 50 to 74, so no one below 50. Then you have most of them had, like, more than half of them had hypertension and so on. You can like look down here. Looks good. Looks like the group kind of like we want to check out, or the ones that we usually see in the ED. They don't stick out in any way like that. And then it's interesting to see like most of these patients presented within the first 24 hours, especially the first 10 hours, and most of them had anterior chest pain. Some of them have posterior chest pain. A few of them have abdominal pain. Even fewer had lumbar pain, back pain. Having any pain at all was 92%, and 10% of them had a syncope. So it's fairly similar to what we just talked about. Okay. So they enrolled around, like, on the lower side of 2,000 patients. And then they kind of did they have conclusive diagnostic data obtained during index ADvISED? Yes, if they had, then they had done the CT imaging or some kind of golden standard, which is also surgery or autopsy. And then they kind of checked which one had a dissection present or not. It's like just right off the bat, and I'll go a little bit into interpretation here, but right off the bat, a lot of these were there's a high hit rate here, like 234 versus 600. So it's like a fourth of these patients that they've sent to the CT scan had the aortic dissection. That's a good hit rate. That's a really good hit rate. Maybe we don't need a test. All right, and then no, if they did not have any diagnostic data, then they were followed up, and then only 2 was lost to follow up, and then 14 days clinical follow up plus admission to hospital or conclusive tests being done. There were some, like 30 patients had a missed aortic dissection. Seven patients had it, and 1,000 patient didn't. Right. So here of these, they did exclude some patients, and you can see the reasons here. Of these patients, ADRS of 0. There was 430 where they did not have any high risk pain features or any other of these features. But they did the D-dimer test, and one of these had a dissection always, but most of them didn't have any. Most of them had a positive D-dimer and therefore a dissection, right? So even this group is quite high risk, right? It's like it's still 1 in 40, something like that. That had a acute aortic dissection when they had an ADDR score of 0. So still a high risk group. 140 is quite high risk when it comes to this group or this diagnosis, right? All right. So if you have this middle group where they have a score of 1, which is, I guess, the most common one, I would say. Then if the test was negative, it's only 2. So that's similar to if the ADRS score was 0, right? But if it was positive, then yes, there's a higher risk of this being a dissection, almost like 1 in 100. Yeah. And sorry, 1 in 10. And of these with the dimer positive one, there was it's like if the test was positive, then yes, the score was like 1 in 4, something like that. All right, and if it was above 1, they did also test the dimer, and here it had a 5 instead of 2 if it was negative. So, and similar amount of patients, a little bit more here. So this is the big main table here. So if the ADRS score was 0 and the D-dimer was below 0.5, you would have a sensitivity of 99% with a narrow confidence interval. And even if it was below 1, you will also have a similar sensitivity, but a much better specificity. And Rebel-EM summarized this as, I don't know the math here, but this strategy will miss around 1 in 300 cases of AAS. Yeah. Given that you can pick these patients out as well as they did, because they say that these were consecutive patients. And that's kind of, yeah. Here are the details of the patients that had a negative D-dimer, and despite having a negative D-dimer, had this aortic dissection. I would say there's a line going here, I would say, between case 3 and 4, because above this you have an ADRS score of more than 1, and this is where we normally would be advised to do a CT scan. So let's try to focus on these down here. And there was one who had an ADDR score of 0 with posterior chest pain, but it wasn't. But they had a high blood pressure at visit. Doesn't say how high. Posterior chest pain. Well, and so there were chest pain involved, but it was just not intense pain and was not radiating, like it was not any of these ADRS score features. And the other one, anterior chest pain and syncope, right? So these are patients that they were not silent patients. These were patients who had pain, but there was no ADRS score. This patient had sudden severe ripping pain, and these are the ones that worry me. These are the ones that we wanted to pick up. With sudden severe ripping pain, these are the ones that would usually go to the CT scan, but the D-dimer was negative here. Yeah. Okay. So going through our checklists. So this is a checklist for a one of these prospective studies. So the first question: the population included a focus on the patient groups in the ED. Yes. Patient representative of those with the problem? Yes. Consecutive but high index of cases, right? So that, and this is a red thread through this JournalClub, that these patients are kind of highly they're really well selected. I'm not sure I could make the same hit rates when I select as they did. All important predictive variables and outcomes were explicitly specified. Yes, this is a prospective multicenter study including a broad spectrum of patients and clinician levels? Yes, I would say so. Clinicians interpret individual predictors, variables, and scores the clinical decision rule reliably and accurately. We don't know. They didn't do some kind of inter-rater reliability score about these things. And this is really important to kind of know what is the inter-rater reliability of this score. So they didn't do that. It doesn't seem like. This is an impact analysis. No. For level 1 studies, impact. No, it's not important here. The follow-up was sufficiently long and complete. Well, it could be argued whether 14 days would be enough to pick up all. It might be because it's such a severe disease, and we're usually told that hours count, right? But I'm actually not sure. It feels, I've said no here, but it could be like a yes/no. I'm unsure here actually whether this was long enough. The effect was large enough and precise enough to be clinically significant, yes. And there was no funding and there was no conflicts of interest that I know of. Summary and perspectives. So, what are the strengths and weaknesses? So, the strengths are, this is an important question because we wanted to both, we want to pick out these needles of the haystack of patients. We want to find these aortic dissections. And we don't want to use too many CT scans doing so, right? So this is an important question. If you can reduce CT scans by using some kind of score. It was a multi-center design, which is good. And it's the first study that's tried to validate the ADDRS score as well. Weaknesses, this is an observational study. We talked about like in the three question sections. Why did they not do a cluster randomized control trial here? I'm no epidemiologist or expert in this, like how to design these research like these studies, but it feels like that might have been the better choice. I'm sure the answer is it was too expensive, but yeah, it was not blinded. So when you don't blind, you introduce all sorts of risk of biases, right? And there was no gold standard, it was a copper standard. So they had this follow-up of 14 days. I don't think they missed too many patients doing this, but there's a potential risk of missing these patients by only following them up for 14 days and not longer, or not doing CT scans on all. All right, so yeah. There's a high index, or there's lots of cases in this. Like 13% of all the patients that were screened had an aortic dissection. That's a high hit rate. The question is, are we as good as picking? Is everyone as good as the physicians in this study to pick out these patients? I don't know. Age-adjusted D-dimer was not in the study. It's something that we don't know whether this works or not. And there was no comparison, right? So it's ADRS score. We should probably have done a cluster randomized control trial where you have ADRS score versus just normal physician gestalt to see which one was the most useful, right? Too many studies are done using scores where it's not tested against an expert physician. What do others think? And this is where what do others think? This is where it becomes really interesting, because in the later, like just after this study came out, most were quite skeptical about this. But in the recent years, tides have turned. So I'll show you. So this is from the SGEM. This is from interpreting what you call the DASHED study, which was a big British study from, I think it's called Tarn Group. They make amazing stuff, really relevant stuff for the ED. I think Dan Horner is part of it from the St. Gilman's team as well. But here's the D-dimer and the ADRS score above 1. Has a sensitivity of 100%, which is similar to this study, but the confidence interval is much greater, right? And the specificity is not as good. So maybe this study has to be validated. But nonetheless, this is what all of these guidelines have said. So this is ACEP, and in 2015 it was no, and in 2025, where this quote is from, the guideline, is yes. So I'll just read it. In adult patients who have an AOD detection risk score or ADDRS of 1 or less, and a highly sensitive D-dimer of less than 500 or 0.5, emergency physicians can exclude acute non-traumatic AOD without obtaining advanced imaging. For patients presenting with chest pain, in whom the diagnosis of thoracic aortic dissection is felt to be reasonably possible, then evidence is emerging that a diagnostic strategy using the aortic dissection detection risk score is likely to be safe and cost effective. This is from ARCM 2024. UK, right? And there's a small nuance there. It has to be a reasonable, it's felt to be reasonably possible. So they don't describe it in strong enough as strong terms as the ACEP did, but still. Then there's the Canadian one. This is the early adopter from 2020. I'll show you their algorithm soon. In those with a moderate risk for AAS, a normal result of a D-dimer test is reasonable to reduce probability of AAS. In patients with a low or high probability of the condition, the use of D-dimer is not recommended. So they were more aggressive. They feel like if the patient has a low pretest probability, meaning that you suspected the condition, but it's such a low pretest probability that maybe the ADDRS score is 0, then you don't need to use a D-dimer. But as we saw in this study, they did actually find some patient, I think it was 7, right, or 10 maybe, who had a ADDRS score of 0. Yeah. So again, it comes back to what is an acceptable miss rate. How many, the lower risk the group, the more the worse hit rate you will get. Like if you do CT scans on all patients in the ED, you will only get a hit rate of maybe, I don't know, 1 in 1,000, 1 in 10,000 maybe. But if you do a CT scan on, if you do the risk, or if you only do it in the highest of highest risk, you might get this, as they did in this study, maybe a hit rate of 10-20%, maybe even higher. So it's all about this, and the Canadians was the most conservative guideline here, the most progressive guideline. They wanted to I'll show you their algorithm soon. In Denmark, we say some kind of in the middle, D-dimer is recommended. Is generally not recommended in patients with high pretest probability of acute aortic dissection. If there's a low clinical likelihood, a D-dimer, not ADRS score, but just a D-dimer rules out aortic dissection. So we went the other way without the ADRS score. And then the ESC in Europe. Early diagnosis is still a major pitfall in managing ADD patients. Therefore, a diagnostic multiparametric algorithm is proposed. I'll show you that as well. It combines the aortic dissection detection risk score ADDRS with the D-dimer and has been validated with excellent capacity to rule out AES. I don't know where they have this excellent capacity from. I'm showing you the same study as they are looking at. I only know of this study that uses the ADDRS score. Maybe the British study that I the Sheth trial could also be one of them. But in general, I wouldn't call it evidence that for strong evidence. Okay, the caveats are then not all guidelines agree. As you just saw, there was a wide spectrum of what they think is appropriate. There's difference in when to use the D-dimer. Canada would not use it in the lowest risk patients. Some specified should only be done with patients with chest pain, not back pain or abdominal pain. That's the ARCM. Some feel it's important to have other workups. The ESC, like the Europeans, the CAPE and the ACEP recommends POCUS, ECG, and X-ray. I guess if you find something other, then the risk goes down. It's not so much. Yeah, it depends. There is one study called the Profundus study that also came out recently, using POCUS, ADRS score, and D-dimer that also got quite good sensitivity. But again, this is such a rare disease, so it's hard to compare. Like, it's all about the selection of patients to begin with. Some feel stronger that POCUS should be part of the workup. That's the Profundus trial. Some say STEMI is most often a PCI. If you see a STEMI on your ECG, then you will not go to aortic dissection. Like, you will not go to the scanner. You will go to the PCI lab. Depends. But there's some evidence out there showing that maybe 1 in 100 of 101, like, you'll miss. Like, you'll be right 99 times out of 100 maybe if you go to the PCI lab with a STEMI. Not any ischemic features, because most aortic dissections have ischemic features, but STEMI features. So here's the guidelines. Here's the ESC guideline from 2024. If you have a clinical suspicion of AAS, then you have to determine the ADRS score, and this is the ADRS score here. And if you have a score that is below, like 1 or 0, then you will do an ECG, exclude STEMI. If you go to STEMI, like if they have a STEMI, I guess you'll go to PCI. They don't specify it here, but probably that's what they mean. Then you might do a chest X-ray and laboratory tests and POCUS if available, but you don't have to. That's how I interpret this. You don't have to do these things. And chest X-ray sensitivity for aortic dissection is horrible. So I don't think that will add anything. The POCUS might, but in the right hands. So if the D-dimer and the X-ray is negative, then consider alternative diagnoses. So you have to consider, but if you don't find alternative diagnosis, I guess then they don't really, like, it's a little bit vague, this algorithm. If the D-dimer is positive, though, then you'll go to the CT scan. If the chest X-ray is positive or the POCUS is positive, then you'll go to the CT scan. So that's the ESC guideline. Here's the Canadian guideline. If you have a high risk physical examination findings, meaning you'll have to go into it to specify, but I think it's probably blood pressure differences, and if the risk factors, high risk pain features, and AAS most likely diagnosis, no, then you just go out of this algorithm. You don't have to. Is there a STEMI? Then you go to angiography. Is there a stroke? Then you go to CT scan. Is there proven alternative diagnosis? And then you also exit. And then you assess the presupposibility first after that. I like this. I like this as very emergency physician. I think it's Britt Long or someone like that who wrote this as well. So emergency physicians doing guidelines for emergency physicians is good. So the presupposibility assessment, and they don't specify how to do this, but if it's low, then you just exit. If it's moderate, then go. If it's moderate, then if you take a D-dimer, then it'll become high, and then if it's D-dimer is negative, then low. So I kind of like this. This is very much how I think as well. But the presupposibility has to be like the big question is, how do we assess this? And I guess they went the other way, where they just said the ADRS score is not validated. You can use that, but you don't have to. Then Then I fell over this great article here. Diagnostic strategies for suspected acute aortic syndrome, systematic review, meta-analysis, decision analytic modeling, and value of information analysis. And even though it seems like a boring paper, this seems like a really, really strong, like one of the strongest papers in this area, I think, just to get at the question about how many CTs is useful to do for this condition. Like, what is fair to what is the hit rate that we're trying to aim for? Because as one of the St. Eminence blogs talks about when they talked about the Sheth trial, is that, well, should we even find aortic dissections? Is it even worth the hassle? Unless it's really high risk. Like, if it's high risk, like pain, central chest pain in a previous smoker and hypertensive patient with Mafang, who onset is immediate and it's ripping and it radiates to the back. Okay, I guess do CT scans on those. But anyone else, if it's lower risk than that, then we just are trying to find too small a needle in too big a haystack. It's too many CT scans, and there's so many other conditions that needs a CT scan more than this. So that's one of the arguments. Like, we should not find aortic dissections because they are too hard to find. It's too labor intensive to do so. That's an argument as well. So, but we haven't went that way. We are not there yet, and we might not be there. But it's worth having this conversation about what is the acceptable miss rate. So, Steve Goodacre made this paper about this particular question. I just wanted to show you some of the graphs from it. So, from my understanding, what they did is, and I don't pretend to understand all the things that they did, but they kind of did this analysis of, okay, so what if we didn't test at all? No patients get tested. We'd take this hypothesis this paradigm that I just talked about, and apply it to clinic. Like, we shouldn't find any dissections. We don't do any CT scans for dissections, suspected dissections. Then we will miss in Britain. They would miss 2,071 per year of aortic dissection. And that would be 8 cases in a typical hospital, but in over the entire NHS it would be 2,000. And how many patients are there people are there in the UK? There's, I think, 80 million, right? 60 or 80 million, something like that. All right, so not a lot. And on the other hand, in the other spectrum here, you'll do CT scans on everyone. How many CT scans will that take? Well, there is, across the entire the entirety of Britain, there are there's the amount of CT scans having to be done are in the entire hospital, entire Britain, is 800,000 to find these 2,000 aortic dissections. That's a lot, and it's not just a small CT scan. This is a big, like, contrast intensive CT scan, right? And in the specific hospital, it will be 3,300. Yeah, and then you'll miss no cases, but you'll only find 8. And I haven't calculated these numbers, but it's like there's a hit rate of maybe 1 in 300, something like that, 1 in 300 ish. And here it's let's see, it's 1 in around 400 as well here. So 1 in 300, 1 in 400. That's your if you CT scan everyone that you suspect, and that's like for 4. That's a lot. That's a lot, and it's always hard with these numbers to estimate whether it's fair or not. Is that an acceptable miss rate or not? I don't know. But it seems like something that where we like to do 400 scans to just find one, and seems like a lot. So how can we diminish that number? So this is the strategy that we're kind of interested in, right? If there's a ADRS score of above 1 or an ADRS score of 1 with D-dimer that is more than 0.5, this is the one that we kind of that's the one strategy that this ADvISED trial proposes. Then we will find 8 cases. Most cases of this, you will do 1,000 CT scans. That's better than before, right? It's a hit rate of maybe 100 instead of 300. And on a global or a national level in the UK, you will find most of these patients as well. And find a much better hit rate also around 100. So you'll still have to do 100 scans to find one. And you might say, oh well, let's not do the D-dimer to make it even better. And then the hit rate is better, but we'll also miss half, more than half. So that's kind of these. Like this seems really nerdy, but this is kind of it's a great example of what kind of calculations we try to do in our heads every day as an emergency physician, not only with this condition but with all conditions, and why we're kind of moving towards too many CT scans, and why we kind of need some kind of framework, or at least some kind of, if I'm using this strategy and I'm the one who misses this, I want a guideline, or I want the hospital to tell me that it was all right because I used this particular systematic approach, because then I'm all right, right? This is calculated into the system. That is part of what we do. It's sadly just bad luck that we missed it, but some of them are missed. We know that with this strategy. Otherwise, we'll just have to do this strategy, and that's just too much, right? That's too much. It's too many CT scans. So it depends. So what they write here down here is that this suggests that CTA angiography for all is not cost effective compared to strategies using ADRS score and D-dimer. CT scans for those with ADRS of more than 1 and D-dimer more than 1 is cost effective at the 20,000 pounds per quality adjusted life year threshold, and with approximately half the number of CT scans required compared to CT of all. So they think this strategy is cost effective. Right. They believe, from what they find, that the sensitivity is around this and the specificity is around this, right? And if clinicians, what they find, what they write here is quite important. If clinicians are able to use their judgments to exclude patients considering to have zero risk of AAS, then a strategy of CTA for patients with ADRS score of more than 1 or ADRS score equals 1 with D-dimer of more than 0.5 would be cost effective and require a modest 60% increase in CTA capacity. So you need to know, like, if we want to not miss these rare birds, then we need to do 60% more CTAs. That's a lot. But it probably would be cost effective according to them. A strategy of ADRS of, or the other one is also cost effective at 3 prevalence of AAS, which is the prevalence of AS in the patients receiving CCA in the DASHED. Sorry, not the SHED trial, the DASHED trial. Yeah. Yes. So it seems like that's tangible. So the conclusion in this study is the ADRS score and D-dimer alone and in combination provide useful diagnostic information, but their use is in the diagnostic pathway for AAS depends upon how clinical suspicion and AAS is determined. D-dimers below 0.5 and a patient with low clinical risk effectively rules out AAS, but unselected application of this rule will lead to higher rates of negative CTA. In an unselected population with possible symptoms of AAS, current validated strategies struggle to achieve an acceptable balance between over-investigation and risk of missed AAS. Okay. So what they were saying is that you can use these tests, but you need to use them wisely. So they say this: ADRS score 1 and D-dimer above 0.5 do CT. This presumably assumes that the ADRS D-dimer study is only applied to patients who would otherwise undergo advanced imaging. If not, application of the strategy to a wider population could have substantial opposite effects. So we really need to, again, and I'm coming back to this question about is aortic dissection. This is only looking at aortic dissection. Some of these patients that have these tearing pains or intense pains that we might want to investigate as aortic dissection might have other things like Burkhardt syndrome or something else. All right, so we might want to do a CT scan on them anyway. But so that's where the thing falls down for me. Yes, we as long as we don't suspect anything more dangerous or other dangerous conditions, then this strategy might work out fine. But if we do suspect other things that are dangerous, then well, I'm not sure. We currently have no reliable way of determining which patients should be suspected of having acute aortic dissection. This is exactly the point I'm making in the ADvISED trial. How do these expert physicians get to the point where they can gestalt or guesstimate which patients should be in the study or not? Did they do focus on them? Did they find other conditions and therefore rule some of them out? How did they do this? It's not specified, and it might not be able to be specified. But what this tangible knowledge, this knowledge on the floor, how do we distribute this, right? Amongst a huge number of patients attending emergency departments with potential relevant symptoms, right? More research is needed how to select patients with predisposition around 2 to 3%, right? That's the conclusion. So to end this lecture, we go back to this patient, 53-year-old man, ex-smoker and hypertension, has this intense pain that came on suddenly and radiated to the back. Do we want to go to the scan, or he doesn't have any other, he has an ADRS score of 1. He doesn't have any other features. And do we want to go to the scan, or do we want to wait for an hour for a D-dimer? And if it's positive, you'll go to the scan. And if it's negative, we don't. I would feel uncomfortable not going to the scan with this patient. I am especially considering that my gestalt tells me that this patient might have this. But I guess we need to be, according to these guidelines, they tell us that we should be comfortable ruling these patients out. I'm not totally sure yet from the ADvISED trial. I'm not totally convinced. I will use it. I do use it in some patients, but not the highest risk patients. And according to Goldegger, this is wrong. This will have the opposite effect. So I encourage you to go to your own local hospital and talk with your radiology department about this. How do you want to attack this problem locally, because or maybe nationally, because this is something that probably should need national attention from emergency physician guideline groups and radiology guideline groups. Yeah, okay. So thank you so much, and I'll see you next time.